Hello, welcome to the latest in IDSOG series of current topic web podcasts for our listeners, membership, and all others who are interested in the topics that we have to present for you. I'm Neil Silverman. I am a maternal fetal medicine specialist at the Center for Fetal Medicine in Los Angeles and on faculty at UCLA Medical School, and my cohort in this endeavor
is, hi everybody, Mark Turrentine. I'm an obstetrician gynecologist and professor at Baylor College of Medicine in Houston, Texas.
So Mark and I had the very good fortune to work together on the recent iteration of the perinatal group B strep guidelines that were issued by ACOG and endorsed by all of our corollary agencies. It was an endeavor that took a major part of the last 2 years of our lives before the final version was published early last year by ACOG and in the Green Journal. Our other partner in crime in this endeavor was Takoa King, who is an amazing collaborator and a clinical professor at the nursing school at UCSF, and who had the benefit of being involved in crafting of the Group B strep guidelines from their very beginning back in the early 90s. And she brought that perspective and her clinical wisdom to the development of the manuscript. The three of us were very honored and proud to be a part of this writing process for ACOG's Committee on Obstetric Practice after the CDC gave the charge for agencies to draft their own guidelines on this topic rather than overseeing an overarching process as they had in the past. So members of our committee at ACOG and a corollary committee at AAP, the American Academy of Pediatrics, basically worked to harmonize the statements that were published very close to each other in early 2020. To be honest, and Mark and I have been involved in writing or editing a number of documents for ACOG and SMFM over the years. This was probably the most labor-intensive bit of crafting that I think either of us have been involved in. We are certainly glad that it's done, but we are also very happy with the input we got from all of our colleagues to be able to finally put together the document that we think will help us and our other provider colleagues to provide the best care they can for pregnant women at risk for or concerned about perinatal group B strep infection. Now that said, Mark and I decided that we would do this in a pretty casual way and talk to you folks about what we think are really the pertinent points that came out of this specific document, and then expand on some of the other issues that we think might be interesting for you to hear about. So Mark, I know we were talking about this. Why don't we talk a little bit about what some of the pertinent modifications in practice that came out in last year's guidelines were? What seems to mind for you?
Well, I think the first one was, the major modification was the change in the timing of the screening. The Centers for Disease Control and Prevention first recommended universal antepartum culture-based screening, I guess, of all pregnant women in 2002, which is still continues in these guidelines. And the studies that were there suggested that the GBS cultures have a high degree of accuracy in predicting GBS colonization at birth if the culture is collected within 5 weeks of birth. The predictive ability of the prenatal culture then drops off dramatically at longer than 5 weeks. The 2010 version from the CDC prenatal GBS guidelines recommended, as everybody probably recalls now, that the screening be performed starting at 35 and 0.7 weeks. But the new ACOG recommended now recommends screening to be performed at 36 and 0 to 37 and 6. And the rationale behind these 2 points is that, first off, the use of antibiotic prophylaxis is recommended as a default for women less than 37 and 7 weeks. The new recommendation for timing for screening provides a 5-week window for a valid culture then that includes births up to 41 and 07 weeks. And I think it's just important, what we realized, I know Neil and Taco and I, when we were looking at this literature, was that almost nearly 2% of births will occur in the 35th week of gestation, whereas approximately 7% of births will occur in 41 and 07 weeks or greater. So our hope was that by changing this time frame, it would provide a little bit better accuracy and that the potential birth would occur within this 5-week window when the screening was performed, and thus reduce some of the discrepancies of having a culture result that may not still be valid at the time of birth.
Right. And, you know, I'm sure you've gotten some feedback from your colleagues. I've gotten a fair amount of feedback from colleagues about why we decided to change it. And I really emphasize to them, as we tried to in the document, that the predictive value of the culture, whether it's done antepartum by a standard culture, or even when it's done by one of the newer molecular PCR-based techniques, appears to have a predictive lifespan of about 5 weeks. So if we move that culture time closer to 37 weeks, that result is going to be valid for someone who delivers even beyond 41 weeks without a need to reculture. So I think that this is a little bit of a change, but there was really logic and evidence behind doing this. And I know I've gotten feedback from folks who don't always like change, as I'm sure you have, but I really try to reassure them that there really is benefit to what we did.
I also think it's important, and I know, you know, that we realize now that most of the cases of GBS early onset disease that occurs in term infants, you know, 60% of them will have a negative culture result. So hopefully this might alleviate some of that as well.
Yeah. The other topic that we really honed down on and maybe over-explained, but probably not, is the issue of what to do with positive urine cultures. So the whole issue of bacteriuria, which I will hint to people listening, is going to be more formally addressed by ACOG in an upcoming guideline that, sort of like Al Pacino in the Godfather movies, I feel like I keep getting pulled back in. I've been asked to be part of it, and you're involved in these discussions as well. But the whole issue of what to do with GBS bacteriuria later in pregnancy. So why don't you tell our listeners sort of where, why we emphasize bacteriuria so much?
Sure. I think what's key, what some of the differences were, you know, is that particularly with regards to the bacteriuria, and this is also, I think, very important, and this will get hopefully to what we're going to discuss in a little bit here. In women who report an allergy to penicillin, and with regards to the bacteriuria, and I assume this is what you're alluding to, Neil, is that if they have an allergy to penicillin and the laboratory requisition then that accompanies the antepartum culture should specifically be marked for the laboratory to be aware of the penicillin allergy. And this is to ensure that the GBS isolate identified will be appropriately tested for clindamycin susceptibility. Now, I do want to stress that the clindamycin susceptibility results are reported on the antepartum GBS positive urine culture are only for the purpose of guiding the choice of antibiotic for intrapartum antibiotic prophylaxis during labor, not to treat the individual at that time with clindamycin.
Yeah, so I honestly, in the past 6 months, have easily gotten a dozen calls from clinicians saying that they had a first trimester routine urine culture that came back positive for GBS, and the lab was reporting it susceptible to clindamycin. Could they use clindamycin? And I did have to go back and explain why we did that, because those women then won't get screened again at 37 weeks for GBS colonization because they've already been shown to be heavy colonizers by virtue of having asymptomatic bacteriuria with GBS. So you need to treat them with something that gets into the urine, which is not clindamycin, and then you can then use clindamycin to treat them intrapartum if they have a significant penicillin allergy. What we also emphasized, and I'll just remind our listeners, is how to define asymptomatic bacteriuria, that it's defined as greater than 100,000 colonies of a unique organism, and GBS doesn't change that need to treat. So we don't treat asymptomatic bacteria unless there's more than 100,000 colonies in the culture, including for GBS. But if someone has 10,000 colonies of GBS reported in their first trimester urine culture, they still get treated empirically in labor, because any amount of GBS that's identified in a first trimester screening urine culture warrants empiric treatment in labor. So we got a little bit of pushback, as I'm sure you remember, about why we were spending a few paragraphs on that topic, but I really think it has practical clinical implications to make sure that people understand what bacteriuria means. And then the two other, I think, specific areas, because I want to save us a little time to talk about penicillin allergy, which we focused on a lot. Interestingly, much to the happiness of our pediatric colleagues, so I was pleasantly surprised by that, is we changed around dosing of antibiotics. So, and I don't know about you in Houston, but I know we've gotten a little bit of pushback from our hospital pharmacists.
We have also. Yes.
About changing the dose of Vanco for intrapartum prophylaxis against GBS. So how do you handle that?
Well, I try to explain to them that this is something that they use, my understanding, in the ICUs in non-pregnant individuals, this dosing based on their weight. And I think we now have good evidence, particularly, and I can let you comment because you were more instrumental in that section on these guidelines, about some of the tissue levels from the vancomycin that were achieved with the dosing recommendation that we came up with. But I know we get a lot of pushback because I guess they're concerned, because they said, "Are you really sure you want to use that amount of dose?" And I said, "Yes, absolutely." They're coming around.
Yeah, I mean, what we realized when we were putting this document together is that there really wasn't any biologically plausible reason for 1 gram Q12 hours to have been chosen in the first place. There was a little bit of information about that dose being adequate to get maternal levels, therapeutic maternal levels in the pregnant woman's bloodstream, but there had never been a whole lot of investigation of whether that empiric dose that was put together years ago actually got into the fetal compartment in a way that met MICs for GBS. And some researchers here in California, down south of where I am, Craig Towers and his group, actually did some well-conducted, small but very valid studies looking at weight-based dosing of vancomycin for GBS prophylaxis, comparable, as you said, to the way that every other medical specialty tends to dose Vanco, which is weight-based, and actually not even ideal weight-based, but actual weight-based. And those are IDSA guidelines. So that's what we tried to do, and it wound up being 20 milligrams per kilogram every 8 hours being an optimal dose. And we're not going to do anything awful to these folks who have otherwise normal kidney function, and we're not keeping them on it for a week. So I've worked with our hospital pharmacists and tried to make that understandable and logical for them. And every now and then we still get pushback, but that is part of the price of trying to change things, I guess.
Yeah. Yeah,
So,
we've actually at our hospital tried to create a best practice alert. We used one of the electronic medical records. I don't want to give, it's one of the major ones. I don't know what the requirements are in this talk about brand names, but so it pops up and it suggests the dose. That was an undertaking we did. So that if you have GBS positive, comes up, this is the option.
oh, well, I think we probably use that same name brand EMR at both of the institutions I consult at. So I'm going to see if I can make that happen so folks don't have to think about it as much, which
I think our motivation came from our pharmacology colleagues because they were tired of getting the phone calls, maybe. I don't know.
Yeah, well, whatever works. I mean,
right.
We really wanted to optimize dosing because newborns did not have therapeutic, the data showed that newborns just didn't have therapeutic vanco levels. And there's no point in giving someone an antibiotic at all if we're not really doing what it needs to do, which is get into the kid.
Absolutely.
So in the few minutes that we have remaining, I would like us to chat. You were really instrumental in expanding this section of the GBS guidelines. I'd really like us to talk about how we expanded the importance of considering penicillin allergy testing in general, and especially for pregnant women who need GBS prophylaxis. So I'm going to hand that one over to you.
Sure, sure. Well, you know, as everybody knows that well, let me step back. I think in evaluating this literature during this revision of ACOG's committee opinion on this topic, it kind of became apparent that one of the common problems associated with the clinical implementation of the past GBS prophylaxis guidelines was the use of a broader spectrum and potentially less effective antibiotic for intrapartum antibiotic prophylaxis against GBS in women who reported a pin allergy. So intrapartum prophylaxis for the prevention of GBS early onset disease is probably one of the more frequent indications for prescribing antibiotics during pregnancy. Therefore, this really serves as a great model for identifying an opportunity to emphasize the use of antibiotics probably in the safest, most targeted manner possible. As we know, and probably our members watching this, penicillin is the recommended first-line agent for GBS prophylaxis. But when a penicillin allergy is reported, you know, there should be a diagnostic approach in which the primary goal is to identify an effective antibiotic with the narrowest spectrum of activity possible. And this is critically important for both the individual patient as well as the greater public health. So I think when approaching the woman that has the pin allergy, particularly for intrapartum antibiotic prophylaxis, there's really kind of should be guided by two approaches is what we took in the guideline developments. First is the woman's history of the pin allergy. Is it a low risk versus high risk of anaphylaxis? And then the other second approach would be if you had a situation where you wanted to do antibiotic susceptibility for the culture results that is obtained. And what is important is that historically all persons with a history of a reported pin allergy were just assumed to have an IgE mediated hypersensitivity reaction. However, what we've learned is that about 80 to 90% of people who have reported a history of a penicillin allergy are in fact penicillin tolerant. So I think what is important in this kind of some work that I know Neil and Takoa and I did after we came up with these guidelines, we actually came out with some clinical expert series in the Green Journal that sort of pushed this even a little further, just trying to suggest that you really should give serious consideration, if it's available, to consider doing penicillin allergy testing in pregnancy. And initially, I guess, gosh, this data, 15 years old now, we had just a very small group of studies out there with less than 100 women total that looked at penicillin allergy testing in pregnant women. And these were women that were colonized with GBS it was typically done in the very latter parts of the third trimester of pregnancy. And what they were found was that anywhere between 93 to 96% of these women would end up testing negative for a penicillin allergy. And I don't know, I know recently there's been a study actually just this year that came out of University of North Carolina in Chapel Hill that was a prospective cohort study where they enrolled women who presented during pregnancy with a reported penicillin allergy. And I believe they approached about 127 women, and I think they enrolled 74. I'm just looking at some of my notes here on this article, but they looked at their primary endpoint was a couple of things. They wanted to see if it was first feasible, which they defined as the number of women who completed testing divided by the number of women enrolled in the study. And then secondary outcome was acceptability, defined as the number of women enrolled in the study divided by the number of women approached to participate, and then safety, i.e. adverse events. And what's important is they used a three-step approach. There's been some controversy with the penicillin allergy testing because it's traditionally always been a skin testing option with the component of an oral challenge. There's been some evidence to suggest that perhaps you can just go to the oral challenge. But what this study did was they took a very traditional approach and did a skin prick, intradermal testing, and then an oral challenge with kind of a graded approach of a low dose and a high dose of oral amoxicillin. And basically what they found was about 58% of women agreed to participate in this. And of those 58%, I think 68% underwent the testing. And then what they discovered was about 93% of these people tested negative, similar to what the literature showed from 15 years ago. And I think what was real critical from this particular study was of the few small individuals that were tested positive by the skin testing, 2 of those 3 individuals, they were detected only on the oral challenge. So I think that's important if institutions are going to consider implementing this. Now we have some really good information from this study from this year that you probably should consider that component. Now, having said that, and trying to pre-pandemic at my institution, I was just actually all set up about to start a penicillin allergy testing program in our pregnancy, which got put on hold, and hopefully we'll get back up again. But there are some real challenges to doing this at institutions. I mean, the logistics of a protocol for testing in pregnancy, you know, you have to have clinical sites that are staffed by the necessary personnel, you know, not only the physicians, but the pharmacists and the nurses. You got to have the required materials for the penicillin skin testing available. And then you got to have management protocols in place for the appropriate medications available in the uncommon event of a drug reaction. And typically it's going to require some time. And that's probably one of the major limitations, is that this has to be performed in a setting that can accommodate a short length of stay, typically 3 to 4 hours. And if in the weird event that you have to monitor pregnant women and the fetus, you know, you may have to have that capability to fall back as well. The big limitations that we've been finding, what I found here, and I've also talked to some of my colleagues in the Midwest who are trying to set up some similar things, is we can't get, at least for government sponsored insurances, we're not able to get reimbursement for this. And unfortunately, I think they don't have the long view in sight. They don't, you know, it's hard when somebody shows up at the beginning of the pregnancy, says, yeah, I got a penicillin allergy, you take a good history, and you're thinking, you know, you qualify for skin testing, but they don't, as some of these insurances, they say, well, what's your indication? And it's like, well, if I wait till they're GBS positive or they're going to get a C-section, that's kind of already the, you know, what's the horses out of the barn sort of thing after the door's closed. And that's the challenge. We just can't get reimbursement for it. And that's one of the areas I think we really need some future research on, is some cost-effective analysis of this. And that's going to be the real next step.
Right. You know, I mean, the long view is really important, because what we found when we were researching both the guidelines and the allergy-specific expert article that we wrote for the Green Journal early last year, is that, you know, beta-lactam antibiotics are the most commonly prescribed outpatient oral antibiotic. And if someone even says they have a mild allergy, then people start running for the broader spectrum, other class stuff, which is way more expensive and typically not as effective. So this is, you know, there has to be a way to convince the folks who pay for this or who do it, meaning allergists, that this is not just so people can get penicillin in labor, although that's important, but it is a lifetime issue anytime they need an antibiotic, if they need surgery, if they, whatever, you know. So, so I would hope that folks would realize that. We have a number of allergists in our area whom I was able to convince. Now, this is not publicly funded insurance that these folks are working with, but I have convinced a number of the reasonable allergists in our area to office test pregnant women, ideally in the second trimester. And I would say, and I email them the PDF of our article, and I've started to send the UNC article to them as well. So I think that a lot of these folks will respond to data and logic, and I've easily gotten in the past 6 months a dozen women penicillin allergy tested between 2 allergy practices in our area. And that's sort of satisfying to be able to get this done efficiently and convince the woman, be able to convince the woman and the doctor both that this is both reasonable and safe. And all of those people were ultimately found to be not allergic to penicillin, because we're not going to be sending people for testing who have histories of anaphylaxis.
Right. No, I think that's awesome. I mean, I wish, and I'm hopefully to get there soon. But and even in this article from University of North Carolina, I think they noted that was one of the things they observed, was that people were more commonly tested if they had private insurance. And I suspect they're alluding to the same issues that I've been encountering.
Yeah, I mean, reimbursement. Reimbursement for so many things is problematic, regardless of someone's insurance coverage, but I think that reimbursement for this sort of thing, to be on labor and delivery for 4 to 5 hours, or a triage sort of area to have this sort of thing that includes fetal monitoring, I think ideally it would be done in the second trimester, where you don't have to worry about fetal monitoring, but something we can work on, and hopefully someone will come up with a large scale cost benefit analysis that can help this as well.
Our next project.
Yeah, next project. All right. Well, I think we have covered this topic within the time limitations that we were given by the committee, and hopefully not beyond the patience level of our listeners. As folks listening can imagine, Mark and Takoa and I can and have talked about this for hours. So we won't subject you to that. But we definitely appreciate your interest and attention to this topic. And we're happy to have been able to do it for you. So
I echo all of that. I agree.
Till we possibly see you next year at IDSOG in person, this coming summer virtually, be well.
Goodbye, everybody.